Good morning, everyone. I am presenting on behalf of Medicine 5. So, presenting Mr. X, 34 years old farmer from Tiruvannamalai, presented with drowsiness for 15 days. He was well before 15 days, then developed insidious onset, gradually progressive drowsiness associated with irrelevant speech for past 10 days. There was no history of headache or blurring of vision or any fever preceding the event. There is no history of weakness of limbs, or deviation of angle of mouth, or recent head trauma. Past history wise, he is a known case of seizure disorder since 22 years of age. Semiology is GTCS. Recently, if he was non-compliant with medication, recently he had breakthrough seizure before 1 month, for which he was started on drug exam Y and Z. Personal history wise, there was no addiction. General examination revealed gingival hyperplasia. No other significant general examination finding. CNS examination finding, patient was delirious, not obeying commands, he was not oriented to time, place, and person, not able to do proper clinical examination at the time of presentation. His GCS was E4, V4, and M5. The only significant central nervous system examination found nystagmus, and there was no neck stiffness at the time of presentation. Summarizing, the 34 years old male with a past history of seizure disorder who is non-compliant to his medication recently had a breakthrough seizure and started on 2 anti-epileptics. Now presenting with altered sensorium and examination revealing the nystagmus and with no neck stiffness. The differentials we considered initially were metabolic causes, infectious causes, vascular etiology, and even drugs. We ruled out most of the causes, and we have even sent drug levels. And what could be the most likely etiology? Yes, as everyone telling, phenytoin is reason for the clinical picture of this syndrome. However, phenytoin is not only the reason for this thing. The investigation showed a phenytoin level of more than 40. The drug Y was phenytoin 100 mg and 200 mg at night, which was appropriate for his weight, and he was taking at the dose advised by the doctor. The second drug he was started on was sodium valproate, 200 mg, 100 mg, and 200 mg. So have you ever noticed this whenever we order a drug? Personally, whenever I feel I get this alarm, I don't even read this, and I will go click yes or no, and I will go order the same drug. And this patient, we stopped phenytoin, and over the time, day 3, his phenytoin levels came down to 35.4. And next, when we examined, he had got other cerebellar signs. And day 5, the phenytoin level came to 26.6. His nystagmus was persisting, other things resolved. And day 7, his phenytoin levels came down less than 20. His higher mental functions were normal. His cerebellar signs resolved. His nystagmus resolved. This phenytoin toxicity can present if the serum level of phenytoin is more than 50. Can even patient present with coma. Then 40 to 50 patient can have lethargy and confusion. 30 to 40 patient has ataxia, slurred speech, nausea, and vomiting. 20 to 30 patient have nystagmus, and in less than 20 there will be no symptoms. So the topic I'm going to discuss is drug and drug interaction. The various mechanisms are proposed for drug and drug interaction. Based on the pharmacokinetics, the drug interaction can happen at the level of absorption, distribution, and even metabolism. The second thing is in pharmacodynamics, the drug interaction happen based on the proposed mechanisms where direct effect at receptor function, interference with the physiological control process, additive or opposed to pharmacological effect. Detailing only one thing, because of time constraint, we are detailing on only one thing: metabolism. The microsomal enzyme induction or microsomal enzyme inhibition. The microsomal enzymes can be induced or inhibited. The drugs that inhibit the microsomal enzymes that decreases the number of enzymes, decreases the metabolism, and increases the plasma concentration of the drug, thereby increasing the intensity or increasing the duration of effect. This is the exact mechanism how valproate induced the toxicity of phenytoin in our patient. Valproic acid inhibits the metabolism of drugs that are substrate of CYP2C9. It is also highly albumin bound, thereby displacing the phenytoin. The second thing is microsomal enzyme induces. This increases the amount of P450, that's a microsomal enzyme, thereby speeding up the oxidation and clearance of the drug, resulting in decreased intensity of duration of drug. These are some of the drugs we use day-to-day life, which are enzyme inducers. The most common we use is phenytoin, PPS like omeprazole, carbamazepine, rifampicin. The most we all know interaction between PPA and clopidogrel, especially omeprazole and clopidogrel. There are several studies done and it showed the toxic effect of the adverse effects when omeprazole is combined with clopidogrel. The other preparation, other things we use day-to-day is iron preparation. The mechanism of interaction with iron normal drugs is iron combined with the drug and forming iron drug complex, thereby reducing the extent of absorption and decreasing the bioavailability of the drug. The drugs which will form iron drug complex with iron is paracetamol, ampicillin, carbidopa, ciprofloxacin, which we use daily, ethambutol, tetracyclines, and thyroxine as well. The next other interaction is warfarin versus antimicrobials. I even have a personal experience with warfarin and antimicrobial. One of a RHD patient presented to the OPD with features of right lower limb cellulitis. I started at the patient at the time of at the day when patient presented, INR level was in therapeutic range, and I started around cloxacillin. The patient presented 5 days later with a symptom of hematuria, and her INR was found to be 7.2. The proposed mechanism between warfarin and antimicrobial interaction where when we start the patient on antimicrobial, there will be alteration in intestinal flora with reduced intestinal vitamin K synthesis. And the next mechanism is inhibition of hepatic CYP2C9 inhibition, and the displacement of warfarin from albumin if the drug is high albumin bound. This is a systemic review done on drug-drug interaction between warfarin and antimicrobial. Several antimicrobial has been found to be found interaction with warfarin. The one we use regularly was metronidazole, cotrimoxazole, amoxicillin, azithromycin. Everything has found increase the therapeutic range of increase the INR value when combined with warfarin. The take-home points are drug interaction can cause fatal reactions. Always, when a patient is on polymedication, we should check for interaction of drugs. Thank you.
Thanks, Lino, for a concise presentation. Any questions? Sure. Thank you all for all your presentations, and the prize for today's clinical meeting goes to Bhageshwar for highlighting the art of watchful expectancy. With that,